Okay, so thank you so much for the introduction. In this talk, I'll kind of be sharing some of our work on interfacing immunotherapy and other adjuvants with focused ultrasound for the treatment of metastatic breast cancer. So first and foremost, talking about the clinical impetus for doing this. Triple-negative breast cancer is, of course, a very devastating disease. There's no cure for metastatic breast cancer today, and breast cancer itself is actually the second leading cause of cancer mortality among women worldwide. So with the fact in mind that triple-negative breast cancer metastasizes to the lung, brains, bone, and liver, we wanted to pursue a model where we can recapitulate the physiology of this metastasis. And thus, we're working in a syngeneic murine model for T1 mammary carcinoma that additionally expresses hemagglutinin for the purposes of elevated immunogenicity as well as to enable downstream tumor-specific T-cell tracking. So in our experiments, we are implanting 4T1HA cells subcutaneously. 2 weeks later, applying focused ultrasound thermal ablation at a fraction of approximately 20%. And something I had to mention that's rather unique about this study is that we're actually using the Theracleon echo pulse visualization and treatment unit in order to do this, which means that we essentially are using a research-grade analog of a device that is in the clinics currently for clinical trials in patients with metastatic breast cancer. A week later, we're assessing the immune sequelae by flow cytometry and also conducting histology to understand the downstream impact of our ablation. Oops. So first and foremost, the figure to the left shows the treatment planning scheme as well as what the outcome of treatment looks like. So with a 3 megahertz system and a 30-watt 4-second sonication, what we're looking at is a hypoechoic region that shows the tumor implanted subcutaneously. Post-treatment, oftentimes we can see a hyperechoic signature at the site that we targeted. And the impact of this currently on innate immunity is that we're, as I alluded to in some previous talks as well, we're again seeing this increase in dendritic cells as in the draining lymph nodes, specifically the axillary draining lymph nodes, as a function of focused ultrasound ablation in the tumor. And more specifically, within that compartment, we see that the frequency of CD86 positive dendritic cells rises significantly as well in the axillary draining lymph node. However, we are not currently observing that this regimen leads to downstream tumor growth control, and moreover, despite the increase in dendritic cells, we're not seeing that this translates to an increase in T cells in the draining lymph nodes or in the tumor. When we dug into this a little bit more, we realized that there is an abundance of myeloid-derived suppressor cells that are essentially ladening the breast cancer microenvironment and essentially causing an overwhelming amount of immunosuppression that we really need to overcome in order to hopefully achieve more robust immune responses. So in order to target this, we are currently employing the strategy of MDSC inhibition using gemcitabine. This has been shown in the literature to confer knockdown of MDSCs in the circulation, and we conducted some studies in-house that basically demonstrated the same thing. So here you're looking at figures where we tracked the percentage of both myeloid cells as marked by CD11B as well as actually can't see this very well, CD11B subsets as well as MDSCs as marked by Ly6G in order to see that there is in fact a transient knockdown in MDSCs as a function of gemcitabine. So in combining this now with focused ultrasound, what we're beginning to observe is that between control and FUS-treated groups alone, we don't really see a significant knockdown and outgrowth. However, when we layer on gemcitabine, as well as focused ultrasound treatment using the same parameters I alluded to before. And I should mention the dosing regimen is on day 14, we administer focused ultrasound and gemcitabine, and then we follow up with 2 subsequent administrations of gem a week apart. We begin to see that there is, in fact, significant growth control of these tumors. And even after the termination of treatment, for almost up to 2 weeks afterwards, we saw that this growth control was sustained. And this is sort of prompting us to unpack questions that may pertain to how much this response is driven immunologically. So we've now harvested samples in association with the mice from this experiment, and we are doing the necessary assays to understand whether this was immunologically driven. So in conclusion, I think I'm just about reaching my limit. In conclusion, our findings suggest that a combination of focused ultrasound, partial thermal ablation, with immunoadjuvants that specifically abrogate immunosuppression may enable FUS to stimulate anti-tumor immunity. Again, our plans are really to follow up on histologically as well as with flow cytometry to understand how these preclinical results may speak to immune modulation with this regimen. And moreover, as I mentioned, the clinical trial will also be greatly informative to the work that we're doing at the bench, as well as vice versa. So with that said, I'd actually like to provide a little shout out for the talk that will happen tomorrow, where Dr. Dillon will be speaking about the clinical trial that I mentioned going on at UVA that is combining pembrolizumab with focused ultrasound ablation. And with that, I'd again like to thank all of our collaborators across both lab members as well as collaborators within immunology and radiology who have helped enable this, Dr. Dillon, Dr. Brennan, who have been invaluable clinical collaborators, as well as our tremendous funding and technical support from Thoraklion. So thank you for your attention.
We have time for one quick question, perhaps. Do you know, have you thought about whether your gemcitabine could be interfering with your CD4 and CD8 populations, or could be skewing them?
Yeah, so we're actually, the flow cytometry that we're conducting right now will hopefully speak to that, but I have no doubt that, the administration of gemcitabine alone could potentially modulate those populations in the circulation, in addition to within the tumor. So it's kind of something we're hypothesizing could be happening.
Great.
Yeah.
All right, thank you so much.
Thank you.
If this works.